thank invite the invitation from the organizing committee for me to join the meeting. Today I'm going to present pediatric antimicrobial stewardship. I will share with you the experience of antimicrobial stewardship in a medical center in Taiwan. And you can see from this graph, resistant bacteria are on the rise, but on the other hand, antibiotics on our hands actually on the fall. And for example, in the US CDC has called for attention from the medical community for the rise of many resistant bacteria, such as the CRE, the drug-resistant Neisseria gonorrhea, and also the C. difficile. Antimicrobial stewardship program is a win-win-win situation for all parts involved, including patients, hospitals, and healthcare workers. Antibiotic stewardship helps to improve patient care and shorten hospital stay, thus benefiting patients as well as hospitals. According to a report from the University of Maryland, the execution of AMS in the hospital showed a saving of $17 million US over 8 years. So this is a good for the administration. And so the three main parts of the infection control and to contain the spread of resistant bacteria are shown in this figure. One is surveillance of the resistant bacteria. The second one is the implementation of different kinds of infection control measures. And the third, also very important part, is the antimicrobial stewardship program. US IDSA actually has published two guidelines, one in 2007 and the other one in 2016, to address the implementation of AMS system for the hospitals. And in the two guidelines, they again and again stated there are two key strategies in AMS implementation. One is prospective audit of antimicrobial use with feedback to the prescriber. The other strategy is the formulary restriction with pre-authorization requirements for specific antimicrobial use. So now I would like to tell you what did we do to turn these strategies or ideas into action in Chang'an Memorial Hospital. Way back to 2004, in Chang'an Memorial Hospital, we built up a hospital-wide computerized antimicrobial approval system for all the antimicrobial use in the hospital. We actually make the best use of the EMR system in our hospital and implement the AMS program into such system. And with this program, we can do a prospective audit and feedback on all the antimicrobial prescription for our inpatients. And so we have a very comprehensive EMR system in Chang'an Memorial Hospital. That system includes a HIS hospital informatics system, an LI system, which is laboratory informatics system, and also an image system, PACS. And antimicrobial agent under stewardship actually are those second or third line antimicrobial agents, or the antimicrobials used in the intensive care units, and also the combination regimens. And now specifically, I will tell you how we do for the prospective audit and feedback. And prospective audit and feedback actually comprises as one of the key strategy as a front-end approach in our AMS system. Here is the working flow for the prospective audit and feedback system in our AMS program. And all the antimicrobial prescription order will be directed to the ID doctor through the computer. And then the ID doctor are allowed to review this prescription in 48 hours. And taking into account all the clinical information, laboratory information, and also image data of the patient, we make a decision to approve or disapprove such prescription. Sometimes we cannot make a decision online. In that case, we will send a message to the prescriber for an official ID consultation. In that case, the ID doctor will be consulted to see the patient on site and then make a recommendation in terms of treatment of the infection to the prescriber. And I will tell you, we actually in 2010 we made a modification on this system, which is the second review system, to help to de-escalate the initial regimen for the patient. I'm showing you quickly the platform we are working on for the prospective audit and feedback. And here is the system, the platform of an ID physician. So every day we receive the information from for all the antimicrobial prescription from the inpatients, and then we will review each prescription one by one, and of course detailedly. And the prescriber will describe the indication for such use on the platform. And then we will review all the necessary information from the patients, including the vitals, the laboratory data, and the chart records, and of course the microbiology results. And we will note the current medication regimen of the patient also via the computer, and we can check all the image data of the patient. And of course, we can have a summary of the vitals of the patient. And based on all this information, we are able to make a decision to approve or disapprove this prescription. And if we disapprove this antimicrobial prescription, we must describe in more specifics on the in this window the reasons and why we disapprove this prescription, and then give suggestions here. And so this is a patient-centered system with all the necessary clinical and laboratory information available for the reviewer. So in that case, we can do the we can have a more clear impression on all the information of the patient, and then with that we can make a decision to approve or disapprove, or give suggestion to modify the antimicrobial prescription. And here I'm showing you the most common reasons with which we disapprove the antimicrobial prescription. And one is the lack of interpretation of the microbiology data. And the second one here is oftentimes we suggest only monotherapy enough for this patient. And of course, oftentimes we suggest different regimen to treat the patient. And this information, this feedback will be sent via computer to the prescriber from immediately. And not only the ID review system, we also have a pharmacist-driven approach for all the antimicrobial use for our inpatients, which is CPOE system. And it is a pharmacist-driven system. Our pharmacists actually focused more on the allergy history and adverse drug reaction record of the patient, and they will warn the prescriber to pay attention to these host factors of the patient. And they specifically will focus on the high-load medication used in this patient, the renal function, liver function of the patient, allergy history of the patient, and also diagnosis of the patient. I think clinical microbiology actually is the cornerstone of AMS. Clinical microbiology provides appropriate and efficient laboratory testing to the prescriber. So it's very important for the effective execution of the AMS. Not only the bacterial culture, very important. Nowadays, the clinical microbiology lab also provide rapid viral testing to the prescriber. And then they also provide a lot of biomarker testing to help prescribers to make more correct diagnosis of the infection, such as the detection of CRP or PCT. And here I'm showing you an example. Here is a patient who is a 4-year-old female, a girl, who suffered from fever for more than 4 days. And physically, we cannot identify for sure the source of the fever in this girl. And the white blood cell is high, 17,000. And also the CRP is high, 47 milligram per liter. And for calcitonin level, on the other hand, is within normal level. So the prescriber actually ordered a rapid viral testing for the patient, and turned out it's positive for adenovirus. So for this patient, no need to give antibiotics, and the fever actually settled within 48 hours. And this is a good example showing that correct and rapid microbiology support can help to improve a precision diagnosis and also to improve the antimicrobial stewardship. Talking about the back-end approach of AMS, the most important strategy is to encourage de-escalation. And usually once an antibiotic is allowed to give to a patient, and within 3 to 4 days, when the microbiology results are available, the prescriber usually should have an antibiotic timeout. And at that time, they should reassess if they must continue the antimicrobial regimen, to modify the antimicrobial regimen, or to stop the antimicrobial regimen. And this is so-called de-escalation time. And in our prospective audit and feedback system, we set up a evaluation system when positive blood culture and stereotype culture of the patient available. So all these positive culture results will be sent to the initial reviewer through the computer. And then we reevaluate for the second time on the antimicrobial use of the patient based on the available microbiology result. And then we make a suggestion to the prescriber to stop or to modify the previous antimicrobial use. And with that, we are able to see the gradual, gradual reduction of the use of second line or even third line antimicrobial use in the critical patient in our ICU. So this is a good example showing that the best use of the EMR system that can help you to do the escalation for the antimicrobial use for the inpatient, even the critical patient. So a lot of unnecessary antimicrobial use can be avoided. And this is a study also, we also, of course, with the new system implemented, I'm talking about the escalation system. We are very careful to see if such modification will affect the clinical outcome of the patient. And turn out mortality rate and hospital-acquired infection rate and also ICU readmission rate did not change before and after the implementation of such the escalation system for the antibiotic use in our critical patient. Here is the table showing that the most common reason we suggest during the second review to our inpatient based on the available microbiology data. As you can see, the most common suggestion we made is to modify the current regimen based on the available microbiology data. We oftentimes suggest a de-escalation for the patient, and sometimes we even suggest escalation of the regimen based on the cultural result of the patient. And in terms of the back-end approach, we also encourage so-called TDM monitoring for prolonged antimicrobial use, especially for critical patients. And also, we encourage all the physicians who are using antibiotics to treat the patient, pay attention to any ADR from the antimicrobial use and then report. And we summarize the result of the ADR induced by antibiotic use to all the physicians in our hospital. So it's very important to make the best use of EMR system. And you should implement your AMS system in this EMR system. And then it can, streamline the work of AMS and also identify a lot more opportunities for improvement for your AMS. And I'm going to address about the outcome measurement. And first of all, you should form an AMS team in your hospital. And this AMS team should include experts from different disciplines. And of course, the most important person is the pharmacist and also ID doctor. And in terms of the outcome measurement for the AMS, one is the process measurement, and the other one is outcome measurement. The process measurement is about the measurement of antibiotic consumption. And you can calculate the so-called DOT or DDD. And of course, based on all the prescriptions or of the antimicrobial use in your inpatient. And recently, according to the guideline from the IDSA, DOT is preferred over DDD for the estimation of the consumption of the antimicrobial agent, because DOT is the consumption regardless of the number of doses administered or the different dosage strengths. And so this is a better measurement for the antimicrobial use for patients with renal insufficiency, with overweight or underweight, especially this is a better measurement for the antibiotic use for pediatric patients. And as a pediatrician, I'm going to showing you for our inpatients, we regularly do the outcome measurement for our AMS system for pediatric inpatients. Here I'm showing you the consumption of the 3rd, 4th, and 5th cephalosporins for our pediatric inpatients. And we usually use the trendy chart of DOT per 1,000 bed days of our inpatients. So we try to control all the use at the within the limit lines. And different lines here in different colors actually indicate the use of this antimicrobial agent in different years. Here's the trendy chart for the use of carbapenem for our pediatric inpatients. As you can see, from 2017 to 2021, first quarter of 2021 actually are quite stable, regardless the occurrence of COVID-19 pandemic in 2020 and 2021. And also in terms of the use of glycopeptides for our pediatric inpatients, it has been quite stable in the past 5 years. And in the guideline of IDSA, you can find it in CID. You can see different kinds of measurements. Again, one is process measurement. The other one is outcome measurement. In terms of the outcome measurement, you can measure the monitor the hospital's length of stay. You should monitor the patient outcome, such as the mortality or unexpected readmission rate to the wards. And also, you should also monitor the C. difficile infection rate in your inpatients. And in the last several minutes, I'm going to share with you another measurement for your AMS in your hospital, which is point prevalence survey for the antimicrobial use. And I think this is on the other, relative to the measurement I mentioned to you earlier, the PPS, point prevalence survey, represents a more easier and also a convenient method to measure antibiotic use across pediatric institutions with variable clinical information systems. And I would like to recommend to you a very good recent paper published in PIDJ. In this study, they report the outcome of 2 national point prevalence survey on antimicrobial use in Canadian children's hospitals. And with this study, they are able to benchmark the antimicrobial use in the children's hospital, of course, for the inpatients. And this would allow the institutional comparison for the antimicrobial use for the pediatric patients. In this study, actually they did one PPS in 2018 and the second time PPS in 2019. Per every survey, they usually work for 1 week. And this is a more convenient and also easier way to measure or to monitor the antimicrobial use for pediatric patients. And in this study, it's very good that actually they classify antibiotics into 3 groups. One is the SS group antibiotics, which is narrow spectrum antibiotic with less potential for toxicity. And the second group is the watch group antibiotics. Watch group antibiotics are those with broader spectrum and also more risk of toxicity and development of resistance. And also the third group is the reserve group antibiotics, which are the higher resistant potential toxicity concerns antibiotics, such as the daptomycin, polymyxin, and also linezolid. And from this PPS in 15 Canadian Children's Hospital in 2018 and also in 2019, you can see that the most common indications for antibiotic use in pediatric patients are lower respiratory infection and also intra-abdominal infection. And what they found is that they specifically pay attention to the antibiotics for community-acquired pneumonia of the inpatients because lower respiratory infection remains to be the most common indication for antibiotic use from the pediatric patients. What they found is that the proportion of watch group antibiotics used in children with CAP is relatively higher in the tertiary and also in the quaternary medical center for pediatric patients. As you can see from this figure, you can see that the blue color bars represent the use of the third generation cephalosporin for children with CAP in the children's hospital. So about 31% of pediatric patients with CAP in the Canadian Children's Hospital actually receive third generation cephalosporin as the empirical agent. So this is quite a surprise to I think to us ID physicians and also probably to the pediatricians. So the point prevalence survey actually is able to reflect more precisely the antibiotic prescribing behavior for different indications in a ward or institution. And this such study from Canada also shows the feasibility of the use of PPS to document antibiotic prescribing features in different institutions. Also, we potentially can use such data as a benchmark to compare the antibiotic use among different hospitals and also to establish goals for decreasing both the overall and also the so-called watch group or reserve group antibiotics for our pediatric inpatients. So in addition to the traditional outcome or process measurement for the AMS execution in our I would like to recommend the PPS as a possible alternative and also an easier way to do measurement for the AMS for pediatric patients. Instead, I think I stop here and thank you for your attention.